Thank you much. It's nice to be back home, a little bit north split. This is my third time this year, so I try to be as much as I can. And also I think local committee and lots of efforts made, especially recently, and I tried to help as much as I could. The EFIC chapter of the in Croatia that it's struggled for a while, and I think that now advancements were made thanks to Dr. Radoš, a couple of other physicians who are really like Dr. Fingler and others who are trying to put together a proper curriculum and advanced education in chronic pain. So we have a very large research institute. We are probably one of the largest, maybe the largest in comprehensive interventional pain in the world. We run about 30, we have now about 32 studies, mainly neuromodulation, so I'm going to talk about it tomorrow. New advancements in neuromodulation that includes peripheral nerve stimulation, dorsal root ganglia stimulation, but also quite a few studies in spinal cord stimulation. We have revolution last couple of years in spinal cord stimulation. I was fortunate to be on the verge of that with the high frequency 10,000 hertz stimulation from a small company in San Francisco, California called Nevro. And but the other part of our studies that we do, and I invested so much time last 5 years, was radiofrequency denervation. So we started back in 2003 and 4, providing some evidence of the denervation of the disc and sacroiliac joints. We fortunately, the small company up from Montreal, Canada, called Baylis Medical, that owned the type of the technology that can denervate properly larger areas of the especially when it comes to the smaller fibers, help us to give a first evidence for the denervation of the disc, proper denervation of the disc, that later resulted in 2 large randomized prospective studies on intradiscal biacoplasty. Then we went on and did quite a few studies on denervation of the SI joint using Synergy technology that eventually has the largest evidence-based literature of all of the denervations, with a large 2 randomized prospective trials and about 24 other studies in the area, and we definitely were able to show long-term improvements in the pain scores and functional capacity. And so more recently, we focused on the knee and the hip. And I was hoping that the organizers will ask me about hip and knee, because knee we have much more data. We actually finished now a very large FDA study. So knee denervation looks really good. First data will be actually presented at the ASRA meeting on the cooled RF denervation. So this is just a much larger lesion. Cool doesn't mean that it would be cool. We just provide much larger lesion. I'll explain this in a second. For the knee, and then a hip, we just started working on it, and me and a couple of guys, we undertook this task to provide better anatomical placement of these electrodes and much more substantial denervation in order to provide better pain relief. And I'll show you a few of those techniques in a second. So these are some of my disclosures. I was consultant for Kimberly-Clark and Halyard now, and previous research grants for Baylis Medical. So when it comes to the hip joint, this is a large joint, and the symmetry allows for rotation around the fixed axis, simplifies muscle actions of that joint. The supply of the joint is very extensive, and the problems related to it are quite common. If you look at the pain that comes from the joint, about 7% of the men and 10% of the women will have the osteoarthritic pain if they are older than 45 years of age. The rates of chronic pain in those who had total hip replacement is relatively high, 38%, and then we know that symptomatic osteoarthritis of the hip affects a very large population of the patients above 55 years of age. So those patients who have a pain from the hip, most of them will have degenerative joint disease, and I'm not going to go to these details. There were quite a few speakers today talking about the causes of the pain. And then other possible causes. Avascular necrosis of the hip is one of the population of the patients that we struggled before, and we had some beautiful results more recently. And then some labral tears and tumors that we also denervated, and I'll show you some of the pictures as well. So what do we have today? What are the alternatives to denervation of the hip? Well, we tried a whole lot of things. Tim kind of detailed that beautifully. We tried different types of structural repairs and regenerative technologies. We tried analgesic augmentative or suppressive injections. And evidence-based literature, especially when it comes to, let's say, PRP, is scant, and we don't really have a good evidence-based literature there yet, or maybe we're not going to have it. So, and then neuromodification technologies, and a few of those include peripheral and dorsal root ganglia stimulation, really did not provide the successes that we were expecting to see. It is superior for neurogenic pain, but really we don't have evidence to support this use of the neuromodulation when it comes to nonceptive pain. So neuroablation technologies are available right now, and we can denervate the joints. So for the hip denervation, our goals are to improve function, to decrease the pain, to improve quality of life in the patients who have, hip replacement, not indicated, and provide some opioid-sparing effect. Tim mentioned about the opioid crisis in the United States, and hopefully Europe will never go through this. We are going through really terrible times as far as the controlling the opioid use, and it's perpetuated by use of the opioids by primary care physicians who are not as educated in using opioids as they should be, and then also by overall need to have minimal pain or no pain. And I understand that, but the alternatives to such extensive opioid use are relatively scary. Now, we do have now quite a few of those interventions that we can provide now comprehensive treatment of the pain from the joints. I mentioned knee, and I'm going to detail you on a hip, that could minimize or eliminate the need of opiates, and I'll explain to you in a second why and what kind of results we got when it comes to the hip denervation. So what are the targets when it comes to the hip denervation? Where are we going to burn? So anteromedial innervation is what we are interested most in. This comes from the lateral obturator branches. And there is another little branch above, which is called accessory obturator nerve, which can vary in position, and that can, in some patients, provide not adequate pain relief that we would expect to see. And then anterior hip capsule innervation comes from the sensory-articular branches of the femoral nerve. So if you remember, try to remember those lateral branches from femoral nerve and obturator nerve. That's enough. Why? Because this is accessible to us, and this is the anterior approach that we can take in order to do procedure in reasonable time interval, be cost effective, and provide long-term pain relief in those patients. Posterior innervation is relatively complex, and it's not or less accessible to us, and there are mixed fibers with motor fibers, so we're not going to go there. So that's how it looks like approximately. So if you look at the joint and closeness of the femoral nerve is an obturator nerve, and you have an idea from your anatomy in medical school that you meet for more medial aspect will be obturator nerve branching the lateral branches toward the capsule as the femoral nerve comes down, and it's more of on the lateral aspect. passing over the joint. So we have some newer data on anatomic variants. So this is a dissection of 7 cadaver hip joints completed by really close friends and folks who are related to CIS. Previously, ISIS, for good reasons, changed the name to CIS. Highly respectable organization that I really like and always happy to almost yearly come to their meeting to speak. They dissected 7 cadaver hip joints, and they basically what they found is that most of the branch offs that cross off from the obturator nerve to the capsule come at the bottom of the incisura acetabuli. So incisura acetabuli is what you see as sort of like a thumb down next to the joint on the fluoroscopy anterior posterior view. And I'll show you that fluoroscopy picture in a second. So also what they found is that at about outer quarter of the joint, lateral femoral branches come along toward the capsule and branch off in a very large numbers. So here you have complex innervation of the lower part of and medial part of the capsule of the joint, with quite a few branches actually being below the incisura acetabuli. And if you imagine this anterior ischium is a little bit more posterior, and your incisura is a little bit more anterior. So what you have if you imagine this 3D, you have a very large space where you have a number of those lateral branches coming toward the joint. So, and then you have this, and even more complex is accessory obturator nerve that may be a little bit higher, and we could miss it in quite a few patients. So what we do in order to figure out who are the patients who are possible candidates for this procedure. So we would place a tiny, and that's what I use. I literally use 25 gauge spinal needle. For obvious reasons, you have a femoral vein, artery, and the nerve coming down. We call this neurovascular femoral bundle. So you try to avoid any damage, and for the comfort of the patient, it takes me literally 2 minutes to do this procedure, and I did about at least 200 of the hip blocks up to now. So what you do, you take a needle, 25 gauge needle, and the first AP position of the joint will be on that outer quarter of the, so this is a joint, isn't it? This is incisura, and you are basically on the upper quarter of the joint, and that's what we expect to see most of the lateral femoral branches coming toward the capsule of the joint. So we would place 1 to 2 cc's, usually of about 2% lidocaine, or you can use also bupivacaine. If you use bupivacaine, it will be 0.5 bupivacaine, and make assessment of how much improvement patient got. The second needle goes at the bottom of the incisura, approximately here, and I do that in the same setting. So 2 needles very quickly positioned down at the bottom of the incisura, touching the bone, and the outer quarter of the joint, again touching the bone, and delivering about 1 to 2 cc's of the local anesthetic is enough to make assessment if and somebody will have improvements in the pain regarding to their anterior supply of the joint. And believe it or not, about 80% of the outflow comes from the anterior supply. So we see really, really great results. Some of the patients who are in a wheelchair start walking first time beautifully. And so you have to, and you should, do 2 diagnostic blocks. And we have a long discussions before. Is that more predictive than 1 block? I would still say yes. It's required for all other denervations that we do in the United States by insurance companies to do 2 diagnostic blocks. And the reason is because with a single diagnostic block, your placebo response can be somewhere between 15 and 20%. That's what we think based on quite a few studies. In some of the chronic pain states, you may even see a higher placebo response than that. So you really want to make sure that patient has consistent response with 2 blocks done on 2 different occasions. So I would schedule patient this week to have a block, get the patient next week to have another block, and then schedule patient for radiofrequency denervation. So there are few studies that initiated all of this work around the hip denervation. And this is the first study. It was a small case series of only 4 patients. This is Malik, another study. That was back in 2003. They looked into the pain scores and decreased use of pain medications and improvement in function. And there were about, out of those 4 patients, and this is really small series, so it's very hard to say much about it. And the problem was also that the size of the needle was minimal, only 22 gauge. So it's like hit and miss. You are trying to denervate quite a few of those small branches, and you're using a tiny, tiny 2 millimeter size of the tip of the electrode that's not going to provide much of the denervation. So the second study, Kawaguchi study, looking into 14 patients, again, 22 gauge needle. And then pain scores went down significantly from 6.2 to 2.7. The question is if it was local anesthetic or the radiofrequency ablation, considering the size of the needle and longevity of the pain relief. So, however, they claim also that 86% of the patients had some pain relief up to 11 months and no side effects or motor weakness. I think it's a little bit too good to be true, but anyway, gave us a basis to go forward and to do more than this. If you look at the approach, and you look at the 2 studies that look into 22 gauge needle, if you look at how they position the electrodes were at the bottom of the incisura, and one so either on top of it or more lateral to the position of the incisura acetabuli, going directly down, basically perpendicular to the position of the nerves. Probably minimal size denervation in either. However, and the sensory stimulation was not done in Kawaguchi's study, which may be for concern. We saw some motor stimulation if you were just a little bit more medial at the bottom of caesura, obviously recruiting some motor fibers from the obturator nerve. So, and then Rivera did another study. This is prospective study on 17 patients, published in Orthopedics in 2012. So again, improvements were quite significant. However, the guide was insufficient, using only radiofrequency. They had 3 hematomas due to vessel puncture, and it's really scary passing by with any size of the radiofrequency needle next to the neurovascular bundle. Any of you who did the femoral blocks, how many of you are anesthesiologists in the room? Quite a few, yeah. So you know, if you did the femoral blocks, it's pretty scary to nail your femoral artery, and you know, especially when it comes to such a large needles. So so they concluded that such denervation can be a good option for the patients with intractable joint pain. So the literature up to the time when we started trialing the larger electrodes to provide larger denervation was a relatively small sample size, tedious technique, requiring multiple lesions. Because if you want to do bipolar lesion, you have to pass many times next to that femoral vein, artery, and nerve. And the risk of vascular injury is so high as you increase the number of passages. So COOL.F came because of the size of the lesion. You can provide this spherical lesion, which can be 10 to 12 millimeters in diameter. And we had such extensive experience in denervating sacroiliac joint. Sacroiliac joint denervation has been out there for about 10 years now, and data are quite extensive. Also, inside the disc, biacoplasty, I did over 1,000 biacoplasties safely and without any complications, which is really good if you look at that we are entering the disc and basically hitting the posterior annulus of the disc. So, so we use relatively large size lesion passing just one time, combining the radiofrequency, combining the guidance by fluoroscopy and ultrasound in order to provide extensive radiofrequency. And I'll show you how we did it. So if you look at where we were placing radiofrequency electrodes, it's relatively easy to place radiofrequency electrode in outer quarter of the joint. So the first effort, and then this will be the guide and possible target for placement for the lateral obturator branches. So bottom of the incisura, as I mentioned before, and anterior ischium. So to develop safe procedural technique, obviously we're trying to avoid vein, artery, nerve from medial to lateral, remember anatomy? And so first approach that we took was the lateral approach, coming from the side, about 75 degrees toward the joint. It seems to be simple, straightforward for the femoral denervation. However, when I tried first in few of my patients going from the side, especially when it comes to the lateral obturator branches, I mean, the passage that you have to take is really 15 centimeters. And the patients scream in pain. You give them fentanyl, you give them midazolam, you try to optimize that, and they still scream in pain. So really, it really didn't turn to be very, very good. 75 degrees was done because that will be below your neurovascular bundle. So you pass below it, and you would not risk piercing of the neurovascular bundle. Even then, it's not clear if this sort of clear you for 100% for not hitting any of those structures. So we took a little bit different approach, advancing the electrode under the ultrasound, combination of the ultrasound and the fluoroscopy. The second approach that was described was inferior approach for lateral obturator branches. As you can see, you can actually come down from the groin area and advance forward. This is for the folks who do not own the ultrasound. So if you have only fluoroscopy, you can advance your electrode, which is relatively large in size, from the groin up. Again, not extremely pleasurable. I tried a few times, and it was quite a bit of a pain in patients. But it's quick. It's if you don't own the ultrasound and you do have fluoroscopy, it can be done in about a minute. So you basically, what you do, you anesthetize the track forward. You follow in AP view your anterior ischium, and you're advancing needle from that position that I showed you before to the target pathway underneath the incisura acetabuli, just in front of the anterior ischium. So you can see now this is the goal, okay? And you can see that the probe was just placed there, and this is where we want to denervate. And we usually do 2 denervations there, and before that we stimulate. So we know that we don't burn any motor branches of the obturator nerve. So this is what we developed. So this is a third approach, anterior approach. And we felt that this was a better way how to do it, combining. And actually, this approach provides us very fast learning curve. So really, we use only ultrasound for one particular reason, to pass by the large vessels. And that's the only reason why we use it. Everything else is fluoroscopy. So we know exactly, we look at our landmarks and position the needle as we pass the bundle using fluoroscopy. So obviously we pass here with the needle, the neurovascular bundle, and with the fluoroscopy we position the electrode. This is the lateral obturator branches, the most important part that you want to denervate. And once when we are at the target, then we stimulate. Then we stimulate with 3.4 millivolts, and we try to get a positive answers. We usually get beautiful concordant pain. The patients say, oh yeah, that's the pain that I have home. And then after that, we do motor stimulation, and motor stimulation up to 1 volt. And if the patient does not have any positive obturator signs, then, or if they do, you just have to basically slide the electrode a little bit more lateral. Just a few millimeters change will eliminate the motor stimulation. And so the final position then will provide us the heating at about 2.5 minutes. And the temperature that develops is up to 80 degrees or using the cooled RF system. So The same thing for lateral femoral branches. You see that my angle is much lesser than the angle that we were doing when we took a lateral approach. And that provides much less pain. So we are able to go straight down, follow and again, vascular structures using the ultrasound, and basically land it to the area where we think that most of the lateral femoral branches pass by. And then we would again stimulate. Typically, what you get when you stimulate lateral femoral branches, you get the anterior and lateral stimulation, and the patient says, oh yeah, that's my pain that I have here and there. And then when you stimulate obturator branches, they usually relate this as a pain in the groin. And after that, I really never really needed. Initially we did some motor stimulation for lateral femoral branches, but really we are so far away from the femoral nerve and below, and there's nothing else there to denervate when it comes to motor branches. So anyway, if you want to feel safe, you can always do some motor stimulation, even for lateral femoral branches before you burn. Again, the protocol is the same for the burning. So if you look at the more difficult one is the first one that I described. So medial aspect placement, getting down to the incisura, and below the incisura acetabulate, doing those two lesions. So the second lesion is done just by slipping off the incisura, getting to the anterior ischium. But what you really want to, this is the more difficult one, because you're just passing next to the vessels. So you are very close. We were, in average, coming to about, in 26 patients out of 52 first cases, we were actually less than a centimeter away from the vein. It's not bad. It's very easy to achieve. You just have to watch it, and that's all. And as soon as you pass, you're kind of worry-free. And so you can see closeness to the RF probe, to the vein and artery. So these are some of the results that we got. So we presented those data. This is under review in a major journal right now. But we presented initially data at this last ASRA meeting in fall, and basically improvements in the pain scores. If you look at just the numbers here, improvements in the pain scores after the first block matched the improvements after the in second block matched the improvements after the radiofrequency denervation. And if you look at the time interval, obviously radiofrequency denervation provided us with much longer time interval. Standard deviation is huge because we included all patients, even those who failed radiofrequency. So if you eliminate those who failed, actually those numbers are even much better, with about 220, 240 days of the pain relief with a single denervation. So in a summary, the anatomic basis for sensory denervation of the hip exists and has been demonstrated. So we are always obviously worried about adjacent neurovascular structures. And to provide safe and effective RF denervation, you have to take those into account. And I think that combination of using the ultrasound and radiofrequency, to me, seems to be better, not because we started and we are the ones to do it. I have now 110 of those, and I still didn't cause a single hematoma to any of the either vein or femoral artery. So strong evidence exists for the RF denervation of the hip. We are looking forward to FDA study next. And so hopefully we'll be able to give you some data in the near future. So if you approximate this and look into the hip, in the knee denervation, hopefully this will be even better. I mean, some of the patients that I denervated really literally went from the wheelchair and start walking for the first time after a couple of years. Thank you very much.